So I'm Benoît Peyronnet. I'm a urologist working in the University of Rennes Hospital in France. And I'm doing mostly functional urology and robotic reconstructive urology there. I'm in charge of the program of functional urology there. I think right now I'm doing only robotic AUS implantation. I'm not using any other surgical approach. I'm not doing open AUS implantation anymore. So candidates for robotic AUS were actually candidates for AUS, and we do offer artificial urinary sphincter to female patients with stress urinary incontinence, mainly driven by intrinsic sphincter deficiency, which we define as positive cough stress test with a fixed urethra and generally a severe incontinence. And we have some urodynamic surrogates to confirm that it's an ISD, usually a low maximum urethral closure pressure or a low valsalvalvic point pressure. The vast majority of patients in our series had undergone other anti-incontinence procedure in the past. About 90% of them had at least one anti-incontinence procedure in the past, and on average it was about 1.5, so meaning a lot of them had 1 or 2 previous anti-incontinence surgeries, but up to 6 previous anti-incontinence procedures in the past in a small proportion of them. There are indeed 2 techniques used for robotic AUS implantation in female patients, the so-called anterior and posterior techniques. And so I'm using the anterior technique, which is basically opening the radius space and doing the dissection of the bladder neck from above, as you would do probably in a radical prostatectomy in a male patient. And the advantage that I see is that you minimize the amount of dissection that you have to perform compared to the posterior approach, where you would have to dissect the whole intervesico-vaginal plane as you would do in a sacrocolpopexy. So it's really a matter of minimizing the amount of dissections that you have to do and minimizing operative time, of course. And that's basically it. But I think both techniques are interesting, and using the robot is really the real asset of those techniques. So, and the disadvantages that may exist is that sometimes the dissection of the bladder neck might be tricky. And so I think that's the point of some of the people using the posterior technique. They believe that you may have an easier dissection of the bladder neck using the posterior technique. In my experience, I am using only the anterior technique, so I cannot really comment on the posterior technique, but I think with going over the learning curve, you realize that I think both techniques are probably the same in terms of outcomes. I do believe so. So actually this was not the matter of that particular presentation, but we did a previous study comparing open versus robotic AUS implantation in female patients. And so we did notice that the complication rates were lower in the robotic group with the robotic approach. There is still some complications, and about 20 to 25% of patients will have at least one complication, but many of them are minor complications such as transient urinary retention, urinary tract infection, or things like that. The really important and sometimes devastating complications that you can experience are device infection or device erosion, which happens quite rarely with the robotic technique. In this particular series of 182 patients, we had 4% of erosion after a median follow-up of over 1 year. So it's really much less than what has been reported in open series in the past, and which makes this technique very promising, and of course they deserve further evaluation, but we really believe that there is a great future for those techniques. I've seen the technique evolving a lot. Also with technology, we have now new robotic platforms available and newer tools in robotic surgery, but we will also see probably newer AUS device coming up, and especially electromechanical device probably, hopefully, without pump and like being controlled remotely. So definitely there will be evolution in this field. On a pure technical standpoint, I've changed my technique a little bit with time, and I'm using less and less vaginal assistance. I used to rely a lot on the help of my assistant finger, and with experience and better understanding of the anatomy and of this procedure, we're able to do most of the cases without any help of anyone, and probably it will help to make it more reproducible. And so yes, definitely there are innovations to foresee in this area.